Good afternoon, everyone. I would like to welcome each and every one of you here to our February 24th Benefits and Insurance Committee stated meeting. This time I'd like to call the meeting into order so we can officially conduct our business. Ms. Corbin, if you would, please call roll for those in attendance.
Rhonda Allen.
Here.
Dr. Andrea Anthony. Here. Doug Bodery. Amber Brown. Here. Shay Crowell. Here. Holly Deering. Here. Brian Gaither. Mary Hickerson. Here. Lois Miller. Alan McAdoo. Jeff Phillips. Here. Shantae Sherrill. Here. Steve Spence. Here. Eric Tutobeni. Here.
We have a quorum. We'll continue to conduct our business. At this point in time, I'll entertain a motion to approve the minutes from our last meeting. Does anybody read them? We have a motion. Second. And a second. Any discussions or changes or deletions? Seeing none, all those in favor of approving the minutes from the last meeting signify by saying aye. All opposed, motion carries. Next we have item number 2 on the agenda item is financials. Mr. Elam, you're recognized.
Yes, sir, Mayor Ketron. So the 264 fund for the month of January 2022, you'll see that, and it also will be the year to date on the calendar year. You'll see for revenue, $7,886,484. Expenses, $7,278,317. Revenue less expenses on the plus side, $608,167. On the fiscal year, your total revenue, $45,065,020 compared to expenditures, $50,763,224. Revenue less expenditures is a negative $5,698,204. For the 266 report, for the month of January 2022, workers' comp, $8,182.89. OJI, $27,399.76. Total for the month of January, $35,581.85. Year to date for 21-22 fiscal year, for workers' comp, $42,794.16. OJI, $283,480.64. And the total for the 21-22 fiscal year is $326,274.80. And that's my report, Mr. Chairman.
Any questions on his report? Seeing none, go ahead, Ms. Corbin, if you would please call the roll.
Rhonda Allen.
A motion.
Dr. Andrea Anthony.
I need a motion.
Oh, wait,
Excuse
I'm sorry.
me. I need a motion to accept his report.
I'll make a motion to approve as presented.
Is there a second? I got a second. Now you may call the roll, Ms. Corbin. Thank you. I'm sorry.
Rhonda Allen.
Yes.
Dr. Andrea Anthony. Yes. Doug Bodery. Amber Brown. Yes. Shay Crowell. Yes. Holly Deering. Yes. Mary Hickerson. Yes. Jeff Phillips. Yes. Shantae Sherrill. Yes. Steve Spence. Yes. Eric Tutobeni.
Motion passes. Next, we have our work comp and OJI report. And for the first time, making a report in this position is Susan Thompson, our new safety coordinator. So instead of sitting up here, now you'll be out front. Let me turn your mic on. You're recognized.
Hello, thank you. I'm reporting on January 2022. For the month, we have 11 incidences. That's also our year-to-date total. Of those 11, 9 were recordable, with 2 being restricted days, 2 lost days claims, and 5 other recordables. On the next page, if you compare this year at 11 to 2021, at the same time we had 18, and 2020 there was 26. The next page of the report is the OJI incurred dollars. For 2022, we're at $57,000. 2021, we were at $72,000, and 2020, we were at $77,000. The breakdown for January, there was 8 claims at the Board of Ed, 3 at County General, and of those 3, there was 1 each at the Sheriff's Office, Property Assessor's Office, and EMS. And that concludes my report.
Any questions? Seeing none, is there a motion to accept the report? I have a motion to approve. And a second. All those in favor signify by saying aye. All opposed, motion carries.
Thank you.
Thank you, Susan. Ms. Lovett, Wellbeing Coordinator, Wellness Update. Welcome.
Okay, so in our Motivate Me incentive program, as of the month of February, we are at 733. Compared to last year at this time, we were at 1,073. We have set up our dates for our mobile mammogram bus for May, July, and October of this year. We are in our 3rd week of our first quarter challenge, wellness challenge. That is a 6 weeks challenge. And for our Wellness on Wheels this year, we're determining how we're going to launch that. Due to the COVID environment, we might go digitally with that this year. And that concludes my report.
All right. Thank you for the update. MedPoint report, Ms. O'Neill. Hello. How are you?
Good, how are you?
Fine, thank you.
Alrighty, we'll go ahead and get right into the visit information on page 3. The health center saw 575 visits in January. 479 of those were for unique members seen. To note, to go with that visit summary, all the health centers were closed on January 1st for New Year's Day, but then we were also closed January 6th, January 7th, and January 17th due to inclement weather, so that did impact our visit totals for the month. If you look at the totals for that, you'll see that in New Salem, we saw 267 visits, Stewart's Creek, 156 visits, and Walter Hill, 152 visits, for a total of 575 visits for the month. On page 4, for our visit summary by member type, we saw 99 children, 400 employees, and 76 spouses. Quite a high number there for our kids. I think it's that flu season going on. In our visit appointment type summary, 71 visits had more, or 71 members, had more than 1 visit in the month of January. To go along with that, 1 member had 9 visits, 6 members had 4 visits, and 64 members had 2 to 3 visits. Almost all of the high number visits were COVID related. We had much higher instance of COVID in January. We had 44 annual visits, 6 dietitian visits, 350 established patient visits, which I'm sure you'll all remember could be anything from a med refill to a sick visit, 35 new patients, 26 nurse visits, 12 telephone-only visits, and 102 telehealth visits with the virtual component, where they have the visual to go along with it. On page 6, for our visit summary by day, in January we had 22 available scheduling days. There were 5 Mondays, 3 Thursdays, and 3 Fridays in the month of January. And I think for the first time ever, Friday was the busiest month for the month of January. On page 7 for our in-person versus virtual appointments, we had 114 virtual appointments in the month of January. And as usual, Walter Hill has the highest average of virtual utilization with just shy of 33% of their visits in January being virtual. Of the 114 virtual visits, 64, or approximately 56%, were for sick care, and 50, or approximately 44%, were for convenience only. And the weather closures may have increased the total of virtual visits slightly for the month because we did still offer virtual care even though the clinics were actually physically closed. And continuing on with our in-person versus virtual appointments for kind of an overall for the year, we have done 11,150 in-person office visits, 2,487 virtual visits for a total of 13,638 visits total. So that means approximately overall about 18% of our visits were done virtually. And in the month of January, just shy of 20% of our visits were done virtually. On page 9 for our referral summary, we had 42 referrals in the month of January, the highest of those being to physical therapy, followed by orthopedic surgery, neurology, gastroenterology, and cardiology. You want to skip forward to page 11 in the financials for the PEPM report. In January, we had 479 total unique members, a total operating cost of $173,653.80, a total employee count including retirees of 6,257 for a PEPM of $28. And then on to page 13 for our diagnosis codes. The encounter for general adult medical exam and acute sinusitis pharyngitis were the top diagnoses for the month of January, though the adult medical exam was vastly higher than any of the others. But you'll see COVID-19 still is on the list again in January, which we had not seen in previous months, even hitting the top 10 list. On page 14 for our visit demographic summary, in January, 66.55% of the members seen were female. The age range of 40 to 49 in the female population and the age range of 50 to 59 in the male population were the highest populations seen. But that being said, we still did have a nice spread with, 62 people between the ages of 10 and 19, 54 with 20 to 29, 79 in the 30 to 39 categories. So not a huge difference there in the age groups, kind of a nice spread of different ages coming into the clinic. And finally, on page 15 for our BMI summary, in January, the female and male members' percent of BMI was in the overweight range for the highest percentage with 25.0 to 29.9. So that being said, we again do have a pretty decent spread there between the BMI categories as well. And that concludes my report.
Any questions for Ms. O'Neill?
I have a question. Thank you.
Commissioner?
Do you ever break out your overhead cost for the in-person versus the telehealth visits? I'm just curious. I know it seems like if I'm reading this right, the telehealth visits kind of follow your traditional clinic schedule, right? So that's like when your providers are available. And I'm just curious if there'd be an opportunity to expand visits, right? If we could do more telehealth, maybe it didn't always follow the same clinic hours, but I don't know if that's cost effective because you're still having to pay for a clinician, and so I'm just trying to figure out what's the overhead difference between an in-person and a telehealth.
So we haven't broken that out individually, but I do know that the way that we do our telehealth visits, because we are so set on making sure that this is a true doctor's visit as if you came into the clinic, we really do not save a lot of overhead as far as staff cost goes there. So they still check in with the front desk. They still talk to the MA, and she does the whole screening ahead of time. Then they see the clinician, just like they would if they came in person. So really the only opportunity that that I would think of to identify off the top of my head, which certainly we could look into more, so this is not written in stone, would be overhead costs, if we could somehow reduce that. The cost of the actual clinic rental building space and that kind of stuff, because as far as staff goes, we're really not saving anything there.
That's really exactly what I expected you to say. I just wanted to ask. Thank you.
Yes.
Yes, ma'am.
Good afternoon.
Good afternoon.
I didn't see any numbers for January of '21. I don't know if you have those. But I did notice that this month, the total number of people who visited the clinics decreased. And I was wondering if that was on par with January last year. And the reason that I'm asking is because January is the first month where we had the $30 copay, and I'm interested in assessing the impact that the $30 copay for the clinics has had on visitation to those clinics.
I did not bring the January numbers with me. I certainly have them available that I could bring next month that we could compare. There's going to be some difficulty comparing, however, 2021 January versus 2022 January that has nothing to do with the copays, and that's simply because of all of the inclement weather issues and whatnot. So, and then if we go to compare February, we're going to have the same scenario, right? Because last year we had Snowmageddon in February. So I think it's going to be difficult in those 2 months to kind of assess, just because the weather has messed with us so much. And then obviously there's been a lot of changes and whatnot. So I'm hoping we'll be able to kind of really get a good picture of that, but I think it's a little soon to really determine that, especially with some of the outside forces.
Have you gotten any feedback from our providers or from their patients about the impact that this might have had in January, the $30 copay specifically?
So the most feedback we've been getting is not really from the providers, because we really aren't changing how we're doing things other than some internal, operational type things that we're doing a little bit differently. The patient isn't treated any differently, obviously, when they walk in the door, whether they're on the HSA plan or on the traditional plan, because to us, they're just a patient, and we're going to give them the same standard of care we've always given with the same options that we've always given. I have noticed that there has been some confusion within the patient population on what they need to pay for versus what they don't, and not having a good, complete understanding of that. So we've been trying to assist them with that, trying to do some education when they're in the practice. I personally have done some outreach phone calls for some confusion to answer some questions. I know that my front desk has been trained very in-depth. Our providers have been trained very in-depth to help them understand why they would pay or when they wouldn't. And I think that's going to be, it takes a while to retrain patients to understand things that are new, and it takes a while to train anyone to understand things that are new. And that's just going to be a process that we all have to go through. But we all are ready with the tools that we need to provide them with that information. Mm-hmm.
Other questions from Mr. Neal? Seeing none. Thank you, Amber.
Thank you.
All right. Thank you for coming. All right, members. Next we have the Mercer presentation. Mr. Brown.
Thank you, Mr. Mayor. So we're going to start with the EAP bid. That is on the iPad, I believe the first attachment, the bid summary. This was done over the last month for a 6/1/2022 effective date. We received 4 proposals. Life Services is the incumbent, the one at the bottom. The proposals range from $1.30 up to about $2.06, and they, if you look at the summary services, kind of vary in number of sessions, hours of critical training, life cycle kits that we currently receive. We had several people kind of review, see what's important to them. The dollar amount is somewhere in the $40,000 range for all the bidders. I believe after review, I think Ms. Stevenson, if she was here, I know Mr. Elam maybe had in their mind that the current carrier does a good job. The dollars are within a couple $1,000s, and that would be a recommendation, but I don't know if there's anything to add to that. Mr. Elam, Sonia?
Mr. Elam.
Yes, one thing I'll point out with the EAP Life Services, they have an office here in Rutherford County. I don't believe the other three have offices here, so they would be able to go on-site, have an on-site visit. And then the life cycle kits is very important to Mrs. Stevenson, and she, gives those out. And when you look at the dollars for dollars, the value for the life cycle kits and the price and the on-site for someone to be able to go and have an on-site visit. I just, after talking to Sonia also, I don't want to put words in her mouth, but we just felt like that the EAP Life Services, we've had good service with them, and it was the better price.
So is that the recommendation, your recommendation to the
That would be
committee?
mine, but I would also like to yield to Ms. Stevenson to make sure, because she deals with them a lot more than I do.
Ms. Stevenson.
So when we looked over the bid information that was provided, based on the items that we utilize, which one is resource kits, and those are things like if somebody has a family member that passes, we do grief kits. There's also some other type kits for different situations that go on in the county. We do utilize that, and the other vendors did not provide those. And even like the Board of Education, whenever they have their maternity, paternity classes, we provide kits for that event as well. And so the other vendors did not offer that. Then there were some other counseling and things that they would do on the side. And so just looking at what the others were going to offer versus what we currently had, it appears that we need to stay with the one that we currently have. They're local. They have an office here in Rutherford County that makes it convenient for our employees, and they're always responsive to our needs. So.
Other discussion before I ask for a motion? Anybody want to talk about the other three? Heard the explanation. Is there a motion?
I'll make a motion to accept life services, and we may want to put it in the motion based on the difference of the kits that help Ms. Stevenson and BOE, but having a local office. For the difference of the $3,800 plus in dollars, we need to go with the life services. That's my motion.
Have a motion. Have a second.
This will refer to
Commissioner
purchasing. This
will go to
recommendation.
purchasing. After your recommendation, any further questions on the motion to go with life services? Seeing none, call the roll, Ms. Corbin.
Rhonda Allen.
Yes.
Dr. Andrea Anthony. Amber Brown. Shay Crowell. Holly Deering. Mary Hickerson. Jeff Phillips. Shantae Sherrill. Steve Spence. Eric Tutobeni.
Motion carries. Next is item number 7, our Cigna Medicare Advantage Plan. Mr. Huffman with Cigna. Oh, in motion.
I think we have a few more things.
You're not through.
We're not through. Not through.
Sorry, Paul, I was trying to get you up here quicker, okay?
We will keep this pretty quick then.
Keep going, Jay.
So the other couple items we want to discuss are an update to the projection that we gave in January. So in January, we had claims through December. We were at a 3% overall increase. With claims through January and updated enrollment, that increase is now a 0. So for 2023, this would be for 1/1/2023, the overall budget projections based on current plan designs and the current population enrolled would be a 0% medical rate increase, 0% dental, 0% vision, and 0% life and disability. And if you look at the projection spreadsheet, you can see the increase by plan. The HSA is calling for a 3% rate increase, the copay a 0%, the deductible a -3. That plan will probably be going away. And then you can see the post-65 retiree plan pretty much each year shows some funding differences where their rates are based on funding for their rates plus some OPEB liability. But our recommendation would be for the overall zero increase to probably just keep all plans at a zero. Zero for the HSA, zero for the copay, zero for the post-65 retirees like we had the last few years, and then look at eliminating the deductible plan, which I believe was voted on last year. But that is the February update for our budget for 2023.
Well, I really like zero when it comes in as zero with those numbers. I'm glad I didn't cut you off. That's pretty strong for projections. Do I have questions on that? No questions on zero? Mary?
You know, I always have a question. I like the zero, but just in looking at this presentation, I want to make sure that I'm not missing anything. You have described this as the 2023 projection aggressive, and then down in the bottom, it's projected claims plus plan revisions, fixed costs, and margins. That plan revision and the aggressive, that really doesn't mean anything. This is projections with no changes, correct? This is as is, where he is today.
Yeah, correct. So the plan revisions are based on, we only have 1 month of data for the decisions we made last year that went into effect this year, mainly the high deductible, the narrow network, some changes to the copay plan. So that is taking that into account. So we really have 12 months of data, but we have 11 months from kind of the old plan. We have 1 month from what I would say is the new plans that we have in place today. We did keep 1 point of claims margin. We know that it is February. We are projecting for a plan that's going to end 19, 20, 21, 22 months from now. So we do have that 1 point of margin kind of to offset any claims we may see in the next few months or even later this year that would go into the next year. But from the standpoint of a zero, we feel confident that the overall increase is a zero, and mainly because we made a lot of tough decisions last year, right? I mean, that was not an easy year, and that has set us up for a solid year this year.
So this does not take into account the, if we go with Cigna's Medicare Advantage, this is not projected in here. This is absolutely pre-post 65 and our current employees, BOE and County General as is today.
Correct.
0% based on changes from last year that will affect 1/1.
Correct. And the next point of the kind of the agenda would be the Medicare Advantage, but so I'll pause there before we move on. Any other questions on the projection? A good point, Mary. So what we said is due to the favorable claims, we think there are some benefits to the Medicare Advantage plan. We've heard some good things about it, and what we would say is we could offer that as an option. If people enroll in it, great. If they don't, that's okay. So, if you look at the agenda, it says for every 10% that enrolled in the Medicare Advantage offering, it could save about 0.2% on the budget. But if we got 0% enrollment in the Medicare Advantage, that's okay. We're still at a 0% rate increase. Sometimes introducing these things as an option is an easier way to get people to understand it. You're going to have some early adopters that may like it and give it a try, but it's not forcing anybody to do anything.
Another question. The elephant in the room, if you will. These projections, will they remain the same if BOE pulls out?
The projections from a claims perspective would remain the same. However, the county general rates would go up some, as we've discussed in other meetings, based on the population change and stuff. But it would be, the only change would be the difference in the utilization pattern, not necessarily a higher projection, if you will. But yes, this is based on current plans and current population for this budget meeting, yes.
Okay, so what do we need to do with this today? I love the zero, and I'm totally on with go ahead with dental and vision, say make it zero and go with it. And I'm okay with medical, but I don't know that, can we truly address medical if we've not addressed who's going to be here in January of 2023?
Well, this being the month of February, we don't have to address this, on a motion. It's just trying to get you the projections. There's a lot of stuff that's going to be coming up, and we're trying to narrow down some of the things. There's so many moving parts and so many, assumptions that you have to make in order to get to these numbers. And somewhere we've got to have a starting point and then move from there. So when we say a zero combined projection, it's with the assumptions that you'll see in the next I think it's the next presentation. But keep in mind, when you look at this combined projection, it says zero. As this thing shifts in one direction to the other, it is the aggregate. It's not what each individual plan will be.
So technically, this still will not affect our rates yet. We're still not even looking at this as projecting that we're not going to have a rate increase. This doesn't tell me we're not going to have a rate increase. Or are we looking at this as we're going to go and say we're not having a rate increase for 2023?
I think it's leaning that way based on these projections. I think it's premature to say we're not going to have one. As at the last meeting, I think I shared with the members that I had a conversation by phone with Miss Lori Lee, the director of State of Tennessee Benefits. And she had shared with me over the telephone in that conversation that she was looking at the state contract because they had been taking money out of a bucket, so to speak, and that bucket is, using Lisa Nolan's terminology, take it out of this bucket. They had been using that to keep their rates static for the last several years. Well, that now bucket is getting empty, so there's going to be some increases at the state level, somewhere in the projections of what she told me by phone, between 7 and 8%. When word got out somehow back to her, she came back and said, well, I need to come down and talk to y'all. So we had a meeting, and she said it's too premature for her to have even made that statement, even though they had one COVID case that was $3.2 million. They had one hemophilia case that was $1.5 million. It's affecting the rates statewide. And she came down and we had a good discussion about that. And she said it's probably going to be more like the 1st of April before they will be able to see what their losses actually look like, which will determine what the state's going to look like and what she'll make a recommendation back to the General Assembly to pass. So I think it's probably we're probably a little premature. Jay, when you say?
I would say for ours, I think every year in February, and I'm kind of looking at Lisa too, we give kind of a almost final number. We do like a preliminary in January, kind of preliminary in February, and then a final March. Is that about right, Lisa? And I would say we've gone from 3 to 0, and I would see it with another solid month of claims in February. A 0 it's setting up to be a 0 in a positive way because of the changes we made last year.
Well, I realize that, and I know some of us are setting budgets and we'll have to take them to boards before they come to the commission and things, so I know we need a projection on that, but I also want to kind of go on and say I would love it for no rate increase, period. It's wonderful. However, I sat on this same committee way back several years ago when there were no rate increases, which was wonderful. And then wham, bam, all of a sudden, we took a huge hit. We decided then, with the help of the county commission, we'd get to a percentage, we'd work our way down so we didn't hit everybody so hard each time. I don't want to get back in the mindset of no increases and then a year or two go by and we just really for lack of a better term, stick it to the guys and employees, I got guys at my work, but on the rates. So, I mean, I like the 0%, but we need to be realistic. I know that's next year and we don't know right now, but we need to look at the life of our policy and plan, no matter what it looks like, past next year.
Very good point.
So do we need a motion that these are presented and we go with a projection of 0% on the 3 medical, dental, vision? Does that need a motion to go somewhere, Lisa, or?
Personally, I'd like to have another month. I mean, I think it's,
I think it's premature.
a month happens. When you were asking what is the plan, and usually you give a shock in January, February. A couple months gives us more realistic of, okay, now. I mean, because you are looking at 11 months from now of what's going to happen. So, I mean, I would prefer to wait a month before we say, these are the rates, and this is what we're going to take.
What's the will of the committee? It's my opinion that we wait another month. Ms. Allen?
Mary said exactly what I was thinking and remembering, excuse me, which was, I think we talked about trying to almost sort of build a reserve pad at like 2 to 3% a year so that you didn't have 1 year with 0 and the next year with 10. So I do think we need to think about that when it does come time to make a decision on this. The other thing is that I want clarification on is and Ed, you kind of alluded to this, is that 0% is the aggregate, right? So we could have individual plans that have different levels of hits. And so I want to make sure, and what we've done, one of the things we've done previously sometimes too is we do a blended rate, so that if we found that one was feeling the pain and one wasn't, we try to blend the rate and sort of balance it out. So I'd want clarification on that to know how are we going to allocate those increases. Are they going to go with each plan? Are they going to be blended? That sort of thing. But I agree. I think it's premature. I would just treat this as information only for today. But I think those are some things we need to talk about going forward.
Okay. So the last thing we wanted to present is kind of following up on the last 2 meetings as well, is assuming that we're at a 0, just assuming that, what does that look like compared to the state for both the Board of Education and the County General, right? Because to Mary's point, there's going to be some decisions that have to be made pretty soon. So if you go to I believe it's called Scenario 1, it's going to have a blue box and orange box, just like it has in the months past. So what we're trying to do here is best compare our plan to the state plan, given what we know about our plan and what we have an idea could happen to the state plan, okay? I was looking on the iPad. So,
Yeah.
331.
331.
331. Hard to read. That's why I had to get the iPad. With me? All right. So this sheet looks a lot like what we've presented the last couple of months, trying to get an idea of what the spend is for our active population, the state spend, for what that would look like for the active population. So if you're looking on the iPad in the blue box, if you're not, it's just going to be the top box. If you see a $56,004,177, that is the spend based on our enrollment today in our plans and the enrollment breakdown that we have currently. That's for the Board of Education. $15,817,000 is the spend we have for our plans and the county general population. And then at the bottom, basically, that's going to be an aggregate. So that's going to give you in that range of $71 million in medical spend for the active population. That's based on our plans and our enrollment. What we're trying to do is see, would it be beneficial to move to the state based on what ends up being some assumptions we have to make. So we made several assumptions. Number one is we assumed if we go to the state for the Board of Education and the County General, we're going to keep the clinic set up as it is today. I believe the state was good with that. I know St. Thomas was good at that. So we had to add those costs into the state budget. We spend around $2 million a year on the clinics. That is already in our rates, right? So our rates, our projections, everything we have includes that clinic cost. So on the very far right of the page, you'll see where we broke it out into the Board of Education picks up 75%, because they have 75% of the enrollment of the $2 million spend, for roughly $1.5 million would be the cost to keep the clinics running as they do today. For the County General, it would be allocated about $500,000 to them. So if we move to the state, we have to take into account that $2 million in spend for the clinics. In addition to that, we assume that if we move to the state and they offer the high deductible plan, which they do, they offer an HSA, which they do, that we're going to keep the contributions the same. Remember when we moved the HSA, we decided to do $500 per year for employee-only contributions into their HSA from the county, $1,000 for the other tiers. So we assume we'll keep doing that. And if you look at the math, for an employee, that's employee only. For Board of Education, that's $41,000. For family, that's $93,000, for a total of $135,000 in HSA contribution to budget for. That's in our rates today. And $45,000 for the County General. Those are two big assumptions. The other assumption we have to make is the state has different rules around spouse enrollment. So quite a few years ago, we made the decision that if your spouse has access to insurance through their employer. Go ahead, Lisa.
I hate to interrupt
No, go ahead.
on this point, because when the folks came from the state to talk to us on the second meeting, that this point was one thing that clarified for me. Just like Rutherford County has the option to allow spouses on, when they go, Rutherford County schools could also have the option of no spouses. So I thought it was a given that when you went, spouses automatically came on. That, am I right? I mean, is that what you got? That it's a decision point from the county to allow whether or not to allow spouses on. So I just throw that out.
No, it's a good point. And so what we're assuming, though, is we're going to the state, we're going to play by the state rules, if you will. That was a point that was made to a positive, that they allow spouses. So we said, well, if that's a positive point, what would that look like if we go to the state and allow that? Again, we could choose not to, just like we could choose not to continue the clinics if we go to the state. We could choose not to fund the HSA the same way, right? There's a lot of things we can choose not to do, but from a comparison standpoint, we're trying to say, what does the state do today versus what do we do today?
As we go forward, though, making these decisions, I want to be clear on who the we is that gets to make those decisions. Because if the Board of Education is getting to decide to go to the state, are they the ones who decide if spouses are on or not? Because I don't know. So we just need to make sure that when we talk about we can decide, I want to know who the we is who's deciding, right?
Yeah, I would say I don't know the answer to the.
I would say right now that the Board of Education has that authority to make that decision. And how they handle it from that point, because under code, BOE comes under a different plan versus County General.
So I think that continues to support the whole idea that we can't make firm decisions until we know what BOE is going to do, right?
Yes, ma'am.
And that's kind of what we're getting at here is we know what our projection in a sense is. We're kind of just saying what would it look like if all these things happened now that we kind of have ours firmed up almost. So if we make those assumptions though, and we did allow spouses to come back on, we're actually being somewhat conservative and saying if you did that, maybe 10% of the spouses come back on, which would be about 100 spouses for the Board of Education and around 30 for the County General. The cost to add a spouse is around $7,000 a year. Now, we saved that years ago when we decided to exclude them, right? And in fact, I think we saved $2 or $3 million total dollars when we, back when we made that decision. So this is somewhat maybe low, but Lisa, to your point, I think there could be a range of things they allow. We don't know. But what we wanted to do was say, if we do these things, you add that to the budget, and then, as the mayor pointed out earlier, we did go ahead and say, what would it look like if we gave the Blue Box or the Board of Education a 6% rate increase, because that's an indication that that could happen for 2023. And for the county general, we did an 8, which is from the meeting what we said could be in the realm of possibility. We can at least now start comparing 2023 to 2023, because up until now, we've just compared 2022. What would it have been if we had made the decision? So if you look at the rates, here's the best way we could come up with to compare it. We had to compare it based on what does the state enrollment look like today, okay? Because there's a whole different set of plans that are offered versus what we offer at Rutherford County today. If you're looking at this spreadsheet, you'll see a line kind of in the middle. Based on a 6% rate increase for 2023 for the Board of Education, based on 90% of the employees enrolling in the small network, which is what the state has today. 90% of their employees in the state plan are enrolled in their small network, which is, if you remember, our Local Plus, okay? We have 25%. First year we've ever offered it, we got 25%. The state has 90% enrolled in that small network. For the Board of Education, 63% of the enrollees are in the Premier plan, the richest, most expensive PPO plan. 19% are in the standard, 14% in the limited, and the state has 4% enrollment in their high deductible. That is the data they've given us with the most current enrollment counts. If you go down one box, you'll see, similar to the county general, we did an 8% increase. They still do have 90% in their small network. They only have 39% in their Premier versus the 63% of the Board of Education, 18% in their standard, 38% in limited, and they have 5% in the high deductible. So the question ends up being, what will our enrollment look like if we go to the state and offer these plans? And if our enrollment mirrored what the state has today, it would actually cost us money to go to the state. Why? Because we have 50% of our population enrolled in the high deductible right now, which is the cheapest plan on that page. So for every person from a budget standpoint who leaves the high deductible and goes to any of the PPOs, it costs us money on the budget. We wanted to show this for several reasons. We don't know what our enrollment would look like. Why did we choose what the state does? Because that's the best data we have. They have 100,000 members across multiple agencies. That's how they enroll. Whether it happened this year or in years future, we assume Rutherford County enrollment would begin to look like all the other agencies in the state. And to Lisa's point, though, that's an assumption, right? We don't really know. But what this shows us is there is the opportunity to save money by going to the state. There is also the opportunity to not save any money going to the state. And it really boils down to what the increase is from the state for 2023 and how people choose to enroll. We've done a pretty good job communication-wise. I think for the last few years, we've always had around 50% in it used to be the HRA plan. People kind of got used to the high deductible. Then we switched it to the high deductible with an HSA instead of an HRA. But for many years, we've had around 50% of our population enrolled in what we would consider our high deductible plan. When I look at this and see that 63% are in their Premier, and then for the county general, it's 39%. That's something that we're assuming that we would probably fall into that category eventually as well. Before we move to the state, I would kind of like to know, is there a plan to maybe make sure we don't lose all of our high deductible enrollment that we've worked hard over the years to accumulate? But again, that is something that from an assumption standpoint, it's very important because it really does show that the details on saving money going to the state versus not saving money really boils down to the increase for 2023 and the enrollment pattern we see from our population. That's the two main points.
I know this is probably a crazy question, but when you looked at it for the Board of Ed and put in the state, you are using their current state with that increase, the 6% increase, what their current rates are, correct?
Current rates times 1.06, yep.
Right.
Yep,
And then the orange, you're doing at our current rates at 8%?
correct.
Okay. I just wanted to make sure that that's what I was reading. Okay.
Correct.
Thanks.
And again, I know there's a lot of data, there's a lot of assumptions, but what we're trying to do is at least be able to compare apples to apples, because up until now, we haven't been able to include the clinic cost in the state. And if you say we're not going to do the clinics, well, that's fine. Well, we would need to remove that $2 million from our rates as well, right? So we're trying to just make sure we stay on a level playing field. So again, there's benefits, and then there's maybe some risk as well. So,
Mary?
In looking at this, I realized that somebody said we could keep the clinics.
Mm-hmm.
How are we going to fund them clinics if the bill is paid out of my rates? Okay, my little portion is paid out of my rates, so everybody's little portion is paid out of their rates. Well, if we're fixing to start paying the state our rates, instead of keeping it in our self-funded, how are we going to pay for our clinics? But it's almost like, okay, Mary, for you and your husband, I'm just using round numbers, $200 is going to be this is round, just simple math, $200 is your rate. So are we going to have to break it down that, well, $150 we're going to pay to the state for your plan, Mary, and then we're going to turn around and put $50 in over here for the clinic? How are we going to be able to make that feasible, cost-effective, when our claims money, rate money is not going to be as rich to pay for the clinics? I don't see how we can fund the clinics and be on the state plan, because how are you going to get that money?
Yeah, I can't answer the logistics of it. I know several people have said it's doable. I trust that it might be doable, but I'm with you. I don't know the logistics of how other entities may do it.
Ed?
To expand on that just a little bit, you are correct on how that the clinics are funded. They are funded out of the 264 fund. There are several different options, not to say that the clinics would go away or the clinics would stay. Again, we're talking about moving pieces here. Just to talk about the clinics, the state would have the Board of Ed would have the option that if they wanted to supplement the clinics and say, well, our portion of that will supplement it based on the savings that they may realize and put it back to the county, they might be able to supplement. Is that correct, Lisa?
I think that kind of was part of the conversation, is that to keep the clinics, then the school board would budget $1 million, $2 million in the budget to go to as a transfer into the insurance fund. That's how you'd get the money from the school board into the insurance fund to pay the clinics.
So that would be part one. If the schools decided not to supplement the clinics, and we have 3 clinics, then we'd have to look at operational costs for that. One of the things that I have asked for from Ascension St. Thomas is to look at an occupational part of the clinic where they would do physicals, they would do all other things in the clinic for the county, and trying to look at savings. I've also met with an adjoining county to see if we possibly could share in clinics, because a lot of their employees live in Rutherford County and commute. So they would, we would have our clinics, and then they would also have a share of it. That's very preliminary. It's just trying to look at the options to where once a move is made, if that's what happens, what are we left with and what can we do? But it's just in the clinics, there's a lot of moving pieces trying to figure out, when we look at the number, the cost of the clinics, do we narrow it down to one clinic? Do we narrow it down to 2 clinics? And what the operational costs will be with that? And then can we do occupational medicine out of those clinics? And that's just a very preliminary stage right now.
And I appreciate your due diligence on that, because it is a moving part and we haven't made a decision. But I guess what I needed to say and put out there and put it on TV is that the clinics are part of our rates. That's how they get paid. And so if our rate money goes somewhere else to the state, then how do we get the money to fund the clinics that stay? And if they're supplementing from BOE or whatever, then are you really having the savings if you're still having to put money back to have the clinics? If you're saying it's going to cost BOE $20 million, and if they'd have stayed with us, it was $22 million. Well, actually, it's $20 million to be over there, and you want to still use our clinic, so it's $2 million here, so you're still at 22. So and I'd appreciate you looking ahead of what will have to be decided, but everybody needs to realize where the money comes from and what the money pays for. It's not just your rate that you get to fuss about because it come out of your paycheck. Well, your money that comes out of your paycheck goes in Lisa's big bucket that pays Dr. Andrews for me, for my visit. Well, also, there's other things, your drugs have to be paid for, and then there's some clinic costs that I'm going to cover whether I go to the clinic or not. So everybody needs to realize we're self-funded. It's our money in one big bucket that we pay our claims with and everything. It's just a bigger picture, and everybody needs to realize where all the money, what your rate actually goes, your premium for each month, what it goes to pay for, not just you're helping to offset everybody. And so it's a bigger picture to look at.
That's good. That's a good point. Other questions, concerns?
I'm scrolling back through the MedPoint report to see, I just can't remember if they ever break it out for us by employee group. Do we know in the MedPoint clinics how many employees are BOE who visit those clinics versus how many are county general? I think that would give us some idea of I think that would give us the value overall on how hard we need to try to retain those. Is
Amber still there? She leave?
I think she would know.
Amber,
I don't think she would know.
We don't keep that data? You do have it?
No.
No, but I'm saying, I'm just asking, do we keep that data? You mind coming back up and stating that? I'm sorry. We'll put you back on TV one more time, okay? Okay.
One, I obviously don't have that data with me today, not knowing to have prepared it, but I think there probably is a way to determine that, just like we can also determine the cost per clinic and all of those kind of things, but we would need to work with the people at risk management to kind of get job codes and look at enrollment data versus patient data to kind of piecemeal that out. We just really have to be careful, though, that we're not bridging any HIPAA violations with that, so it has to be, very global in how we do that information.
Okay. Any other questions before she sits back down? Thank you, Amber. Any other questions, concerns? Well, what's the will of the committee? I'm all.
Got another scenario. Scenario two.
Okay.
I think we're good, but we've covered that scenario. I mean, are there any questions? Are there any questions for me?
Kind of what I'm hearing is that no action be taken today, that we wait another month? Everybody good with that? I'm seeing some heads nod, so, all right. Then, without any motion, Alan?
I do have just one other observation, and I appreciate, I like when we get into the weeds a little bit sometimes, when we dig into the details. I think that's important for us to make these decisions. But I also don't want to lose sight of being so hyper-focused on 1 year that we're not looking at long-term. That was always one of my concerns about staying self-funded versus going to the state. The trends that we've been looking at, how sustainable is it to stay self-funded? I don't know. I just genuinely don't know the answer to that question. I know there's a risk with going to the state as well. But I just want to make sure that we're doing the level best we can to make informed, educated decisions and looking at industry trends and trying to anticipate the longevity of either decision, right? Because it's going to be awfully hard to undo, one or the other. So just make sure that as you're advising us and you're guiding us, and Ed, as you're doing your due diligence, that we do the very best we can to, again, yes, look at the minutia, but also look at, 10 years down the road, what's going to be the best decision overall. And I think that ties back to, do we keep clinics? Do we need clinics? Do we expand telehealth? If we go to the state, do they have more urgent care clinics, and so there's more access? There's a million things, a million moving parts to this, and so I just want to make sure that we're trying to look at each one of them. With that, I will make a motion that we just take this information under advisement for this month and take no action.
Have a motion. Have a second. Discussion. Ed, were you going to make a
That's
comment?
fine.
You're good? Okay. All those in favor of the motion? Aye. All opposed? Motion carries. We'll defer till next month. Okay. Jay, that concludes your report?
That's all from me, yes.
Now, Paul. Okay, Mary?
Well, he give a piece of paper out and compound annual growth rate. I don't need a lot of explanation, just is it important? I mean, I know it's important you put it out there, but how should we look at this? This is actual claims cost, or is that the state and local gov is seeing this much of a claims cost increase, or are these premium increases? Did I read it right that it's claim cost? Do you see?
I am looking here. I'm trying to get my iPad back open. Yes, it's CAGR, compound annual growth rate, and the state ran it for the Board of Education and for the County General, and then we ran it from a Cigna report based on our claims over the last 5 years. And I'm trying to pull my iPad back up. I have it here.
So I'm thinking, are we good at 3.9 or are we bad at 3.9?
We are.
Is it good to have a higher number or a lower number on this one?
Right, so this is just claims and pharmacy cost on a per employee per month basis year over year. So this is not increase in what comes out of someone's paycheck. This is not necessarily increase by plan. This is just overall claims cost. And the reason we ran that report, Commissioner Allen, kind of to your point, was to look at how are we tracking versus the state, and how are we tracking versus other entities as well. And something in that 3 to 4% range is pretty good. What you'll see, though, is exactly like it's been stated today. I believe, was it 2021, the state had an 11, we had an 8. Sometimes they have a 2, we have a 4. So it's very cyclical. And that is the other thing we want to be cognizant of moving to the state is, are they in kind of an upswing, or are they maybe in a downswing? I know Mr. Elam mentioned earlier about a fund that maybe they're spending down some on, and how long does that get to go on for? If that runs out, then do the increases that are 6s stay 6s, or do they go from 6 to 3 like they have in the past? And that's the kind of information we're trying to gather more, especially from the state. But that was the point of that report, is to show that it's cyclical and that our compound annual growth rate is right in line with other entities. Good call out.
But, and to go back over what Ms. Lori Lee told me, in that phone conversation, that bucket of money is being depleted. And I don't think that General Assembly is going to put more into it. So I think that with those 2 claims I mentioned in particular, their claims are on the increase. And or at least their rates are going to be increased as well. Sonia?
So we've talked about a couple of different things, and we've looked at the possibility for savings for medical and pharmacy, state versus county, but we also talked about some things, and Mary's brought it up, and others, that you know, if they utilize the clinics, then that's another $2 million that's subtracted from that savings, because it's not a savings. Then you also look at, currently our retirees are rolled in to our overall rates. Our pre-65s are part of our plan, and so if they only take their active population and have that savings, they're still going to have a cost for retirees depending on what they do, if the retirees go to the state too, or if they stay with the county. So I think one of the things that we need to consider, and again, I don't know, based on prior explanations, that this body would have a say-so whether or not the board made the decision to go, but I think it's a little bit bigger than just the savings on the medical and pharmacy, because when you add the other moving pieces in, then you have to say there's going to be a cost with that, so that's going to offset your savings. And then adding, you know, years ago we made the decision to remove the spouses if they had access to insurance, and it wasn't because we didn't want the spouses to have insurance, it was because we wanted to, you know, to manage our premiums. And so going back to adding spouses back in then kind of puts us in reverse of what we did several years ago to actually save money. So I'm not sure how, at the end of the day, what the true savings is actually going to be, you know, one way or another. This is not, you know, that's not my expertise. As finance office tells me, stay with people, Sonia, not numbers. But big picture, I mean, I can add 1 + 1, you know, and kind of look at it. So I'm just curious. Anyways, it was just an observation that I just felt like we're not going to see the savings that we thought that we might see.
Well, I think that's why we're choosing to wait another month. We need another month of data so we can see what the trends are before we can make that determination. So I think the motion was an appropriate motion to wait till next month.
This is actually, thank you. This is actually a follow-up to what Sonia was saying. I know we're doing the salary survey, and I think you were trying to factor in benefits to that as well. And so I'm curious if that's one of the things we need to consider, which is, I know one of the things that we've heard the school board say is that, you know, this change to the state is going to make them more competitive in terms of, you know, recruiting and retaining talent. It just makes me wonder, you know, the market was at a different place when we made the decision to remove those spouses. And we've talked a lot about what it costs us when we have employee turnover. And so, again, this is one of those pieces, one of those moving pieces that we need to factor in globally in terms of what does it cost us? What, you know, what's the ROI, right, on allowing spouses potentially back on? So as we look at that, we need to make sure that we factor that into this decision. That's part of that global big picture landscape that I want to make sure that we're looking at, and not just looking at individual premiums today. So,
Well, if we go back to a couple of the other presentations, trying to get apples to apples, first assumption we made, if everybody in the county plan went to the state plan and went into the exact same plan, then we gave you that one big large assumption. Now we're coming back and saying that, and if I remember correctly, you've got to be in the state plan at least 2 years before you can opt out. I believe, I'm not sure, but there's a period of time you have to be in there. And what we're looking at is that if everybody says, well, we want more options, and they take those options, then how, you know, what Mercer was tasked to do is, how do we mirror the state? If we look at it 3 years from now, and our percentages of people are in the same plans as what the state enrollees have now, how would we mirror that? So that's where we came in. Okay, here's the assumption with the spouses. If an employee only moved to employee spouse in the state plan, it's a higher rate. And that's why, you know, we're trying to narrow down a little more apples to apples here, trying to get of, as you're saying, what is it going to look like 2 years from now, 3 years from now? And these new hires that come in, you know, what plan will they pick? Well, if you go to the state plan and try to mirror the state plan, as Jake said, what is that cost going to be to the county? And what I will say is like, no matter how many times you dive into it, no one has a crystal ball. And when you sit there and as the state said to us, we have a stop loss. Rutherford County has a stop loss above 750, and there's a reason why. Because it kind of moderates things a little bit more. Instead of in the state, they don't. And when you have a 3 million point whatever claim, that plan takes the hit. So even though you have 100 and something thousand enrolled, you also have it spread out over several different plans, which dilutes that 110, just like ours is diluted with 2 plans. But in the same reality, and I brought some notes up here. Even though the state may say, and just like Rutherford County does the same thing, the state may say the aggregate rate increase that we're looking at, premium increase may be a 6.1 2017. They can pull some money out of reserve account and get that down below 6.1. But in 2017, the limited PPO went up 23%. 2018, the limited PPO went up 23%. The aggregate rate for those 2 years was 6.1 and 7.1. So I don't want to mislead the audience or anybody out there when it says the aggregate rate is 6.1 and you get your premium increase and it's 20-something%. And what happens is that particular plan took a hit that year. And that's where the difference was. That's why it increased as much as it did. It's so hard to say in 2023 who's going to be sick, how sick they're going to be, and what that cost is going to be. But Mercer puts a model in, figures out what it's going to be, and gives us a number, and we just hope we're close to it. I will say this. For us, and I'll go back to the tracker, if you look at for the year, we finished for the entire year 2021, the entire tracker for the calendar is 0.009 deficit. Revenue versus expenditures, it's a negative. Now, Lisa's the numbers person. She can dive into it a lot more than I can. But to go through COVID and to set those rates for 15, 16 months, not knowing what COVID was going to do, getting with Cigna, getting with Mercer, and getting our models and trying to say, where are we? When you look at the number, you're off $700-something thousand deficit, but it's 0.009 for the fund. And I think that's, it's a big number, but then it's a small number when you look how much you're off. And a lot of hard work went into that. And then, like you say, you don't have a crystal ball. You just hope at that time, what is COVID going to do to us? What's it going to do to the plan? And we made adjustments, made some tough adjustments, but that we're just all trying to do the best we can.
Sonia.
I have a question. I want to make sure I'm remembering this right. And this is to Commissioner Allen's point about looking at recruiting, looking at, long-term, because recruitment changes. It's based on what's going on at that period in time. I mean, and that could change to tomorrow with everything that's going on in the world. That could change. So when we look at a recruitment, one of the things that they always look at is salaries. That's one. What is your salaries? And then what is your benefits? The other part is the benefits. I hear people say, well, the newer people that are coming in are not as interested in benefits as they are their salaries. I hear that, but then when I talk to people out in the workplace, I hear, well, no, we're very much concerned. We really want best of both worlds. We want pay and we want good benefits. When the state presented their information, if you retired pre-65, is that the option that if you were not hired by July 1 of 2015, you were not eligible for, or is that the post-65? Do you remember?
think it's pre-65.
I thought it was pre-65 too. And so one of my things from a recruiting tool too is you look at, you know, for me, the reason the 65 is in the sand is because at 65 people can go to Medicare. But if they meet the, you know, we have people that work in lots of employees in the county who start working with the county at age 20, and at age 50, they got their 30 years of service and they can retire, which means that they could keep that pre-65 benefit until then. And I think the conversation is that the county didn't offer that. It was kind of presented that the county cut their employees off in 2009. Well, that's just not true for pre-65. Our employees pre-65 still gets their stipend, correct? It's just if they meet the bucket post-65, whether they keep a benefit. And so I think that's another thing that we need to look at. I mean, if it's pre-65 and anybody who was hired at the Board of Ed after July 1, 2015, if they retired, if they came to work at the county at 25 and worked for the county for 30 years and they're 55 and they want to retire, then they've got from 10 years that they're going to have to look for benefits elsewhere if they were hired July 2nd, 2015 and moving forward until they get to 65 for Medicare. Whereas at the county, with the pre-65 that we currently have, they would get a stipend to actually offset those costs that they would have to do outside. You know, you could say that the county doesn't offer anything, but that's not true. I know that could change. This body could say we can't afford to do that anymore at some point in time, but as of today and as of the plans that we have right now, that is still an option. So for 10 years, that would be a benefit that the county is currently providing, that should the Board of Ed move to the state, anybody hired July 2nd, 2015 moving forward would not have the same opportunity, if I'm remembering it correct. So I may be wrong, but if I'm remembering it correct. That would be a huge recruiting tool in my mind.
Other comments? Seeing none, we have another presentation. Paul?
Well, all I was, no, I put this on the agenda because we've talked about it for several months. Just trying to make sure if anybody had any questions that Paul was available to come up, answer any questions that you have. There's not really another presentation or anything. And just to try to show how this all ties in also to what our rate projections are.
I'm going to call on Mr. Tutubeni. He's one of our citizen members on this committee, but this is what he does for a living. So, yes, sir. Please come on up. You're recognized, Eric.
Afternoon. Actually, I just want to talk a little bit about the difference between Medicare Supplement and Medicare Advantage. I know a lot of people are confused about them. First, let me say that I'm not a county employee. I have nothing to gain or lose by this. But for 26 years, I've run Cornerstone Financial. That's my company. Mainly, I'm a financial planner. I help people to plan for retirement, financially secure. Well, that involves a lot of people that then are moving on to Medicare. Basically, there's two options. Now, first I'm going to talk about the private section, and I promise I'm going to be very short, too. This won't be long. In the private sector, you have straight Medicare, Medicare Advantage, or Medicare Supplement. If you're on straight Medicare, it's just an 80-20 plan. The government pays for 80%, you're responsible for the other 20%. You have Part A and Part B. Part A is the part that covers the hospital. Part B is the part that covers going to a doctor, specialist private doctor. So how do you deal with that 20%? That's the part that, as a citizen, you're faced with, an American citizen. A Medicare supplement is something that you can pay a monthly premium for, and it wipes out the 20%. You go to any doctor you want, it's free to go to the doctor. Those generally start at around $100 a month when you're 65. But each year they go up just a little bit, a few percentage points. By the time you're 70, they're more like $150 a month. By the time you're 75, $250. By the time you're 80, close to $350 and so forth. On the other hand, you can get a Medicare Advantage plan, which has no monthly premium to it at all, but you pay small co-payments when you go see a doctor. So generally, the primary care doctor is free. Specialist might be around $25, $30. You have certain co-payments when you go into the hospital, certain co-payments when you have lab tests done. However, there's an annual cap of out-of-pocket, generally, and there's specific numbers, but just generally between $5,000 and $6,000 a year, that you can never be out-of-pocket more than that. The Medicare Advantage plans also include full dental, vision, hearing, chiropractic. They have the full pharmacy plan built into it as well. If you get a Medicare supplement plan that you're paying a premium for, you've got to go get your own pharmacy plan as well. That's typically anywhere between $30 and $80 a month, depending on the plan design that you want to get. So, on the most affordable side of things, if it's $100 for your Medicare supplement and $30 for your prescription drug plan, then you're looking at about $1,500 a year out of pocket. Keeping in mind the Medicare Advantage plan has around a $5,000 maximum, so as that price goes up year by year with the Medicare supplement, it makes sense to eventually switch over to a Medicare Advantage plan. Okay, so that's the private world. In the group benefits, it works very similarly in that in a group benefit of a regular Medicare medical plan, it beats what an individual can get in the private sector. Well, the same is true with a Medicare Advantage plan in a group setting versus getting it in a private setting. So what I'm always trying to weigh as part of this board here is, since I'm not a county employee, if I were a county employee, what would I like best? But also as a citizen, tax-paying citizen, what's the most cost-effective way? And I know that's the struggle and the balance everyone is trying to deal with there. So let me tell you, for those of you not familiar with the Medicare Advantage plan, which is also called the Medicare Part C, same thing, federal government regulates it. There is no downside, there is no trick, there is no what's the catch. There isn't anything like that. It's just the lack of familiarity with it that you might think in your mind, well, this is too good to be true. No, because it is paid for by the federal government. That's where the funding comes from. If you think about being just on straight Medicare, you've got an 80-20 plan basically for free. You're not paying anything for that. Now, Part B, there is a Part B premium, which is $148. However, for those of you unfamiliar with Medicare, I hope I'm not confusing you here or getting too far, but where does all that money, where does that 80% the government pays that 80%, where does that come from? Well, that comes from the collective pool of money. Well, that money is made available to the private insurance companies, provided the law is provided that they meet what the government provides, but they always exceed it. So, in short, what the private companies do, and by the way, I'm licensed with all of them, Cigna, Humana, Blue Cross, United Healthcare, Anthem, Aetna, WellCare, Amerigroup, you name it. I'm licensed with all of them. So I have no particular favorite. When I sit down with a client, I find out what their needs are, what it is they're interested in accomplishing, what's best for them, and then I look at the plans that focus in on that. Okay? So in summary, I just want to say that when your choice is between a group Medicare Advantage plan like the one that Cigna is offering the county employees versus the plan that is the Medicare supplement plan, because we're talking about over 65, right? It's over 65 only we're talking about, right? Okay, so this doesn't affect anyone under 65. All day long, I would vote for, if I was on the receiving end of the Medicare Advantage plan, no question about it. Because not only does it meet all the needs that an individual is going to have, but adds to it the dental, vision, hearing, the chiropractic, the podiatry, all the prescription drugs included. There is no downside to it. But with that said, whatever you think is best is fine. Because I'm not a county employee, and I'm not going to be on the receiving end of it. I wish I could sign up for a plan like this. I got to do it on my own. I'm still 6 years away. I'm not that old yet. I'm only 59. Just had a birthday. You can all wish me happy birthday, by the way.
Yeah, happy birthday.
Birthday.
Oh, yeah, thank you. Yeah, I'm 59. I'm going to get a cane next month. So, in the general sense of Medicare Advantage, supplement, group benefits, where my expertise is. 26 years I've been in this. If anyone has any questions, fire away. Yes, ma'am.
So, is this a true statement that with the Medicare Advantage plans, there are co-pays?
Yes.
But
Now,
is there-
I have to take a close look at the one, because I don't have it in front of me. The general public, yes. Are there co-payments? There's co-payments with this, aren't there? We designed it so that it's 100% covered. Oh, my God. Can I please sign? Can you all make me an honorary county employee? I want to be an honorary county employee, please. Can you offer me a job? Let's negotiate afterwards. Okay, so, all right, I left off one thing that'll tie right in with that. Now, there is a third category of Medicare Advantage plan for people who are on TennCare, or on what's called QMB, which is qualified Medicare beneficiaries, which is people that are on low income or have a disability. In that case, they get a plan where everything is free, nothing costs anything. They go to any doctor they want, all free, zero. And they pay $1.30 for prescriptions. Is that, Paul, is that similar to what you're talking about, the special needs plan, the SNP plans? Oh, I'm sorry. The plan that you're offering the county employees that has no co-payments, similar to the SNP plans and special needs plans to the general public, people that are on TennCare and on QMB. They have no cost. I'm comparing it just in a cost basis. There are no costs to any doctors with those plans. 0 equals 0, yep. Oh my God, yeah. There is no downside to this plan. There just isn't. So I recommend you just look up a Medicare Advantage, Medicare Part C, Google it, just learn about it. Now what you're going to get is a million ads trying to sell you it, okay? That's just, don't pay attention to Joe Namath on television, nice guy, not knocking Joe Namath. But those ads on television are just to entice you to call in, and it's a bait and switch situation there. So if you got anyone's available, is free to call me at any time. I'm always available. But I don't see any downside to it.
Yes, sir. Thank you.
Am I done? I'm getting kicked off the stage now.
Well, I think everybody's...
Unless you have a question.
No, I don't have any questions. Does anybody have any other questions? I'm just, we all have other...
I'd like to just clarify something.
Yes, ma'am.
Correct me if I'm wrong, but if you just do Medicare, the Part A and B, that 80/20 is forever. There's not a stop. Like you don't have a maximum out of pocket. Is that correct?
You're correct, and that's why there's Medicare Advantage and Medicare Supplement plans.
Why they're so much better.
Now, some people are just really healthy, and they just say, no, they don't want to have anything else, and they're welcome, to have that. But, yeah, there's no end to that.
Right. Thank you, Eric. It's very informative. Thank you. Question, Mary?
I guess I have a statement, because we have had Mr. Paul provide us information, present us information. We've done this, I think, at least 3 months now. And I am one to look and see, is it too good to be true? And I've said it several times. I still can't find out what's wrong with it. But I'm putting it out there. I really think that we need to at least make a decision on this for our retirees, because it doesn't, and it's just my thinking, it doesn't affect anything else yet, whether who's here or not, come January 1st. That'll be a whole nother decision. But as they live today, which I know this will go in effect January 1st, I think for the better of our retirees, because of plan costs are getting outrageous, and Cigna has brought us a real decent, nice Medicare Advantage that mirrors what our post-65 retirees currently have at a cheaper rate. I think that this doesn't need to be an option, it needs to be the option of our post-65 retirees. Now, I know there will be some eligibility language that would have to change, because right now, some post-65s don't get prescriptions and that can be worked on. But if we have a direction for the insurance department to do, that gives them a direction to go in instead of what if on everything. So with that being said,
I'm gonna hold you before you do that.
Okay.
Before you make that motion, I'm gonna call Paul up one more time.
Okay.
Okay, and then I'll let you make that, I'll entertain that motion. Paul? Okay.
Okay.
Ed?
Did you have?
So, Paul, a couple of things I want to make sure we have clarity on. We discussed this morning, one of the questions was the clinics. Would the retirees have the use of the clinics, and how would that look?
Yes, we would still be able to access the clinics just as they do today. And because the benefit is 100%, there's no change in benefit. They would still be able to access the clinic if it's available, and still receive that 100% benefit.
We would just have to do the reimbursement according to Medicare reimbursement, right?
Yeah, good point. So because it's a fully insured Medicare Advantage product, it's no longer your money coming out of your fund to pay for it. You're not paying the clinic for it. The clinic would then need to submit a claim to Cigna, just like they're used to doing as a medical contracted provider with Cigna, and then Cigna would reimburse them for those Medicare Advantage members just as they would any other Medicare member that went to see them.
Okay, and another question is, I noticed in a presentation to the Board of Education that we talked about, I think, I'm trying to remember the lady's name, Jen.
Yeah, Jen Cutterback.
Yeah.
Yeah.
She made the comment about a 60-40, 60% in-network, 40% out-of-network. And, if Jennifer wants to speak up, the retirees are... they've seen these doctors for a long period of time. They're very comfortable with their doctors. They want to keep their doctors. So when you start making changes, the disruption, and as I said last month, the disruption to those retirees it's just critical that we don't have it. So again, I want to make sure that's on record. The concern was the 60-40 in-network and out-of-network. When people go to their doctor, if they see Medicare and they take Medicare, is there a roadblock between, well, we take Medicare, but we don't take Cigna's Medicare Advantage Plus plan?
Right. So let me clarify that. When she mentioned 60-40, that was just a round number in her head at that time. So right now in Rutherford County, for the providers, so we ran a specific report. We looked at your Medicare Advantage utilization currently today, those providers that they're utilized, and we looked to see who is contracted in our Medicare Advantage network today. As of right now, it's close to 69%. So those are what we consider contracted, meaning that doctor is all in. They're accepting, they've got an agreement with us, they know the reimbursement rate, and there's no question. Okay, well then, we also feel like we're going to grow that number over the next year by another 9%. Okay, we anticipate as more and more physicians and doctors and providers understand the product, understand the reimbursement, they're going to sign on and truly be contracted. So what's left is what's that last 22% that we call non-contracted or out-of-network. How does that impact employees who were seeing those doctors? That's the question. We developed the plan design so that if someone goes out of network, they get the same benefit. It's still 100%, okay? So that erases much of that 22% because doctors who don't contract with us can still see you, can still submit a claim to Cigna, and they'll still receive Medicare reimbursement, even if they're out of network, and the member will still not have to pay anything. all right? There is a fraction of providers who, when you call, a Medicare Advantage person calls to schedule an appointment, they say, we don't have Cigna, we don't take Cigna. And that member will say, well, but I can go out of network to see you. We can't stop that provider from saying, I still won't see you, okay? And that's what we've run into. There are going to be a handful of providers that don't take a contract and will not see you, even though we would be paying them the Medicare reimbursement. Okay, so those are the ones we are trying to reach out to and educate. We ran into a group, I won't mention them, that kind of surprised us, but we are educating them, and so they're going to be in the network. We're going to work with them. So that's the only drawback, Eric, that I could say, is there anything out there that's a negative? And that, most of the time, can be resolved with a conversation or a discussion with Cigna to explain the whole process to them.
And one follow-up question, I think you've answered it. We deal with a lot of retirees that are out of state.
Mm-hmm.
So basically, what you're telling me is it doesn't make any difference inside the United States. It doesn't make any difference where you go.
That's correct. So with a Medicare Advantage PPO, it does not matter if the person lives anywhere in the country. They can sign up for this plan and access providers in their own location. And it will either be in network or out of network under the same rules that I just talked about.
Mary?
Just a quick little snippet on doctors in and out of network. I've been here a while, so I can remember back to when we had Blue Cross. When we talked about going to Cigna, some of the doctors and the little group of doctors, and well, we don't have for the Cigna, and they didn't. I mean, there was pushback big time. Well, y'all, they're all in here now. When they realized that Rutherford County took their 12,000 some odd lives and went to Cigna, not that we've got, but when you see a large employer do that, the doctors and everybody realize that this is important, and what you've got is education, and it's took us 3 months of education and extra looking to realize that this is in good. So I just, to put it out there, that when we switched to Cigna for everybody, there was still not everybody in there, but they got on board when they realized what it was. So that's on that.
Commissioner.
So if I'm a provider and I'm going to get paid the same regardless, what's my incentive to sign a contract? What changes?
Mostly the ease of administration. So submitting claims, receiving electronic payment. Sometimes we may, in order to be in the network, that we may actually do a smaller reimbursement. So if they want to stay out of network, they're going to get Medicare reimbursement. In network, we might have slightly less. I don't know those numbers between the two. That's a good question, but I think most of it's going to be an ease of administration of working with us and getting paid.
Sonia?
So I had a couple of questions just on the paperwork that was provided, and I think I know the answer, but I want you to clarify. So on the summary of benefits, where it talks about what the member pays, and where it says maximum out-of-pocket cost, it says 0, which applies. So that's saying there is no. Is that saying there is no out-of-pocket?
Correct.
Or wait, let me say, there is no maximum, or there is no out-of-pocket. Which
right.
is it?
Because there's no member cost share, then there's no maximum
okay.
to be made.
Yeah. That's what I thought that I was reading, but I was like, I want to make sure. And then the other question, it says on here emergency room, and it says waived if admitted. Do you know what the cost would be if somebody wasn't admitted?
It's probably just language on that benefit summary that's standard, because it probably doesn't apply because there's not a cost to begin with. Yeah.
And then on the exclusions page, it talks about that benefits that you do not cover, and one of them is the experimental medical procedures or surgical. And my question is I know that for sometimes with cancer patients, especially if it's a unique type of cancer, that there may not be
a current medication that somebody could use, and so the doctors feel like they don't have their only option is experimental. Is that something in those type of situations that if the doctor proved medical necessity, or is that just a flat exclusion? Or do you know that?
Yeah,
You may not know.
that's a tough question. I would say generally we're going to go by what Medicare rules are for what's covered and what exceptions and exclusions are. However, because you've got the group Medicare Advantage program, we've added additional options. In those unique situations, I could see it going either way. If it's an off-label medication used for a different, I've seen those get approved, okay, and that's not necessarily under the experimental or investigational definition, but things that are unproven, so if it's something brand new, doctor thinks this is going to work, if it's unproven and untested and undocumented, it may fall under that investigational and it would be denied at that point.
That's what I was wondering, because sometimes they're just saying, we don't know of a medication that can help
Right.
you. And so this is like our only option. And so,
Right.
and then my last question is, it talks about routine chiropractic care except for manual manipulation. So under this, that would not be something where we currently have some visits under chiropractic. They wouldn't have that unless they needed it for subluxation or whatever, right?
So are you saying that they wouldn't have it?
Yes, it's under your exclusions. It says routine chiropractic care except manual manipulation of the spine to correct subluxation unless noted in the benefit summary. So I guess if that's something that we opted into, it would be included.
I can take that away because if that was designed to mirror what you currently have today, and if we've got chiropractic covered under the current OAP 65 plan, we can get that put back in there. So that may be something we need to correct.
Okay.
Yeah, thank you for pointing that out.
Thank you.
Other questions for Paul? Seeing
Question.
none.
I got a question.
Yes, sir.
Or just a comment to get him to answer. Funding by the county, the minimum funding by the county.
Yes, so the group Medicare Advantage PPO does require an employer to contribute at least 25% of the total rate. So, and our rate was $204.75, so if it's $200, then we would expect the county to contribute at least $50. I think right now you're contributing $300 or something like that toward the $600. So that's just a rule we have in place to ensure that it remains a group Medicare offering.
Other questions for Paul?
And next thing also is minimum enrollment for this. For instance, we're talking about the schools. If the schools take retirees, what's the minimum enrollment for this?
I believe it's just 10 employees or 10 lives. Yeah. 20? Man, I should have brought my print out. I'm sorry. 20. Thank you.
All right.
20.
Mary, I cut you off. Are you ready?
That's okay, if everybody else is ready. Okay, let's address for Mary's personal opinion on the contribution by the county, because it has been mentioned just in passing and other things that we could do away with, right now we're at 50 on some and 75% on some of the funding. In Mary's personal opinion, the county, because it's our county retirees, we should be contributing something. And if it's as minor, even if we did the 50 and 75% we do now, it's still a savings on our OPEB. It's still a savings if we stayed the same. So with that being said, and even having the mandatory 20 people on it if BOE pulls out and the 25% funding from the county, I think we need to do this, and I think this needs to be all in and not as an option. This needs to be a good plan that we offer to all of our post-65 retirees. I know this figure is less BOE, but if they happen to not pull out, that's fine. And this is what we need to do. I'd make this as a motion that we change all of our post-65s to the Cigna Medicare Advantage plan, starting 1/1/23.
Have a second.
Can I ask a
Several
question?
seconds. Now, questions on the motion. Lisa, you got your mic in your hand.
Yeah, I would just follow up with Mary. We've already gone through of how much the county is going to pay for these benefits, I say we still follow that.
That was my question, was the
That's your
contribution
question.
from the county. Did we follow the same as we are doing now?
My opinion is yes. The language reads on county contributions to the retirees the same as it is today for all the lines in the sand that have been drawn. And we do realize that drugs will be, pharmacy will be they'll get some. Some of our post-65 people will now pick up the pharmacy.
Yes.
So that's my motion.
Sonia? Question, Sonia, and then Lisa.
And if I'm remembering this right, even if we went to the 50% that we're doing now, this is still a cost savings to the county, and it is a cost savings to our employees for a greater benefit. Am I right?
That's correct.
Okay.
That's the way I understand it. Lisa?
This might be a little off than what we approved on our lines in the sand, because if we go to this, then you do have groups that did not have pharmacy will now have pharmacy, because we can't carve that off. Get pharmacy. But the to our plan is the contribution stays the same.
Hey, Jeff?
I just want to ask our risk management department, Ed, is this something that you, from a county's perspective, are ready to endorse at this time?
Commissioner Phillips, based on the information that I've been given, based on the review, the many, many meetings that I have had, and with the contribution remaining the same, with the post-65s would be able to get pharmacy, because I think, there's a bucket, and I wasn't here during that time, but there's a bucket of people that will not have that benefit of pharmacy. To be able to put all that together for a C, yes, based on the information I have, yes, I'd endorse it.
Thank you. I'm maybe old school, but when somebody says, this sounds too good to be true, there's always some catch over there. Is there any of that? Is there any negative that you can come up with, any?
I don't at the moment, but I have dug into this. Later on, the 25% came up as we kept from the first meeting to, I think, to maybe the second meeting. We thought at one time that, if the county did no contributions, then it would really drop the OPEB by a lot. But now, with the minimum 25% in there, it will reduce the OPEB, it will reduce the cost to the county. Jake, what was the total amount if it's all in instead of just optional?
It was $1.5 million or so in savings. So the last month that we looked at that, it dropped the overall increase about 1.5 points overall.
Commissioner Allen?
And I just want to clarify, I think we've talked about this before. This can remain a standalone policy whether we remain self-funded or go to the state. Is that correct?
Yes, that's correct.
Sonia?
I'm sorry, I just want to make sure that if anybody's listening that they don't get confused. This doesn't change our current bucket system that we have, our GASB plan. So anybody as of 2000, well, except for the pharmacy. So if somebody was not an employee as of 12/31/2010, that they're still at 65 would not be eligible for this plan. It doesn't change what we already put in place for that. So I didn't want somebody listening to think, okay, I'm an employee and now I can count on this at 65. It doesn't change what we set up for our GASB plan to reduce that liability years ago. It just means that the people that are eligible under that GASB plan who were not eligible for pharmacy in the past are now currently eligible for it. I am right in that assessment, right? Okay.
So to the point of it's too good to be true, Commissioner Phillips, that it's kind of there, even to the point where one of our private citizens on the committee would like to become a teacher, right? And matter of fact, I think there's a bill before the General Assembly that you can be covered now to go teach without a certification, right, for 3 months. I think I saw that on TV last night because of the need for teachers. So, you know, I think it's a good plan. I totally support this plan. As my blessing.
Is it not possible to have a phase-in, like give the retirees a choice for a year or so?
I think phase-in insurance kind of phases in. It's either
phase-in is not the right word. I'm sorry.
Yes, sir.
But is it possible to give those retirees a choice to stay where they are for the first year and get accustomed to the process and then take it the next year? Is it possible for that to happen?
Paul's shaking his head, and so is Ed. I think we could do that.
I'm just thinking.
They're shaking their head in the affirmative.
Hearing from some retirees, that was one of the things I think that they were asking.
Sure.
Once again, I'm not advocating that, because this other thing is it's too good to be true, so I would certainly endorse that. But what if the retirees said, you know, I'm skeptical, I'm leery, I want to stay where I am until I get some experience in
Yeah, I think that's doable, right?
One more. Last month, Paul, I know I asked you the question about any calls from your clients, not naming names or anything, but I know there's some that's implemented in the last couple of months. And just what feedback have you gotten since the last meeting?
Nothing. So the ones that I had experience on implementing for January 1, 2022, to be honest with you, I have not run into any issues or feedback regarding even the out-of-network providers that we talked about. So enrollment went very well. We actually provide staff and the communications and the education to do meetings for your retirees, as many as you need. So we'll do the educating as much as you wish so that we can answer those questions.
Okay. Anything else for Paul? We're talking on the motion itself. Any further discussion on the motion? We're going to go on the record with a roll call. Ms. Corbin?
One last clarification.
Hang on.
I'm sorry. One last
One more.
In a couple of the other presentations, we had 2 or 3 different plans, so I want to make sure that we're narrowed down on the exact plan that we're talking about, and it would be the Medicare Advantage Plus, the PPO, custom medical, and RX.
Correct.
Mary,
Correct.
Is that your motion?
That's correct. It's the one that has I think the rate was $204.75. Yes.
Yes, because we had 3 different plans, and I just wanted to narrow that down.
Yeah, that's the one we
for clarity.
designed to mirror your current medical and current pharmacy.
For the record, that is the one.
Correct.
That is your motion. Yes, ma'am.
Just point of clarification. The motion that we're about to vote on is to adopt this plan with the change to chiropractic care, correct?
That is understanding. Is that correct,
Yes.
Mary? Is that your motion?
Yes.
To include chiropractic?
Okay, thank you.
Anything else on the motion?
The motion does not include an option to stay where they are, correct? I'll make a motion to amend that motion to allow at least a 1-year option to stay
All
where
right.
they are to go.
So I have an amendment to the motion to allow for 1 year to phase in. Is there a second for members to phase in? Have a second from Mr. Tutubeni. Discussion on the amendment.
I'm curious, your motion, is it based upon just fear of the unknown from a couple people who've called you?
It's for some retirees that are sitting out there that want that option.
Okay. I don't understand why. Can you help me understand why they would need this or want this?
We've kind of been through this before.
I'm sorry to make you repeat yourself.
We've gone through changes to that 65 retiree, and we thought there were benefits to it, but the retirees came back, even though we thought there were benefits to it, they were leery of it, and there may be some of those things that are out there now. I'm not saying that I support it. I'm saying that there are some retirees that are out here that are asking at least for that option. And that's the reason I presented it. If this
Amendment.
this amendment is voted down, I'm going to vote for the other one, okay?
Well, so we're voting on the amendment for a one-year phase-in. Does everybody understand the amendment? All in favor, voice vote. All in favor of the amendment, signify by saying aye. Aye. Motion fails, lack of a majority.
You asked for opposition.
Say what?
You didn't ask for all those not in favor.
All those against, signify by saying aye. Okay, motion fails. Oh, on the amendment. We're back on the original motion with no amendments on it. Let's call the roll, Ms. Corbin.
Rhonda Allen.
Aye.
Dr. Andrea Anthony. Amber Brown. Shay Crowell. Holly Deering. Mary Hickerson. Jeff Phillips.
Yes.
Shantae Sherrill. Steve Spence. Eric Tutobeni. Sure. 1, 2, 3, 4, 5, 6, 7, 8, 9.
Motion passes. That brings us to the end of our agenda. Let me make a comment real quick.
Okay.
I'm going to make a comment. Last week, I received a phone call from one of the members of this committee out of concern of what was on being put out on social media. And let me just say that the person, we know who you are, and I'm talking to TV if you're watching, we know who you are that posted that. But the comment was that Rutherford County was doing away with all health insurance for its employees. And then it started getting legs, and I started getting other phone calls from other people concerning that. That is mean-spirited. I know it's an election year, but that's very mean-spirited to start something as bad as a rumor like that when it's dealing with people's lives, their medication, and everything else. So I took the liberty and wrote a letter to all employees and sent it out blanket to all employees. I hope all of you received that. So, and anybody else, you're just as guilty if you were spreading that on social media. You're just as guilty as the person that posted it. So I hope you'll consider that, but we do know who you are. Anything else to come before us? All right. We'll see you next month, and maybe we'll have better data. Thank you.